One of the questions that came in, Enrique, was about your stability index, and I thought that was a very fascinating slide. I was curious if you could talk a little bit about what the pieces of the stability index were, and you said you came in July. Like, what were some of the things that you think might have contributed to the increasing stability that you were seeing over that time period of that year?
Yeah, so before I came in, kind of our dosing practices were not very uniform, I'll say. So I put a cap on total dosing to 24 milligrams, and much like what Megan's doing, so I did a lot of teaching, and so kind of our average patient would be started after I came in, started on 16 milligrams total of buprenorphine with a cap of 24 milligrams. Now we do make exceptions, that those aren't absolute rules. We also had patients that were being dosed, TID or QID, and we limited it to BID to reduce diversion, and just other things like, what are the criteria for getting somebody, for getting them into IOP, what type of patient needs psychiatry. So I'm a psychiatrist. That's my background. So teaching a lot of providers with medical backgrounds. These are kind of the flags, and these would be reasons to get somebody in to see our mental health nurse practitioner. So those are some of the main things that I implemented when I started about a year ago. As far as that stability index, again, we have a paper that we are currently getting ready to submit to some journals. So I don't want to give it all away, but some of the main things that you would expect, like appointment adherence, showing up to your appointment, certain urine toxicology findings we found were more predictive than others. Fentanyl and norbuprenorphine, not big surprises, but we hope to publish that in our paper and show exactly, how each factor, how predictive each variable is.